I'm going to go ahead and begin and allow people to join us while I do the introduction. I'm Robin Axel Adams. I am the manager of the Fairbanks Center for Medical Ethics. Thank you so much for joining us remotely today for our lecture. This is our final lecture for the 2021 Ethics Lecture Series. And so we'll be back September 1st to kick off our 21-22 series. So look for those announcements. A few preliminaries for our lecture today. We appreciate, as always, your understanding of any technical issues that may develop. We've learned so much and technology works well, but not always perfectly. As a reminder, just like every other month, you will receive a link to the evaluation for CME and CE tomorrow. If you're watching it live, at the email address that you use to register for this webinar. You must complete the evaluation to receive credit. And this month, the evaluation will close on Sunday, June 6th. So we encourage you to fill out the evaluation, though, even if you don't need the credit, because this helps us track our attendance, but also allows you all to provide feedback. So just a note about the CE and CME. This webinar is being recorded and it will be available on our website, fairbankscenter.org, within the next week. And those recordings are also eligible for CE and CME. And so we encourage you to send your colleagues that information. The Q&A box is available to post questions, but I will be asking Dr. Bosslet and Martin at the end of their presentation to answer the questions. And finally, Drs. Bosslet and Martin have no relevant financial conflicts of interest to disclose. All right, let me introduce to you two wonderful people. Gabe Bosslet is the Associate Professor of Clinical Medicine in the Department of Pulmonary, Critical Care, Sleep, and Occupational Medicine, and is Assistant Dean for Faculty Affairs and Professional Development at Indiana School of Medicine. He is also the Fellowship Director for Pulmonary and Critical Care Medicine and the affiliate faculty member of the Warren Fairbanks Center for Medical Ethics. Dr. Bosslet received his bachelor's degree from the University of Notre Dame and his MD from The Ohio State University. He completed his residency in internal medicine and pediatrics at The Ohio State University, Columbus Children's Hospital in Columbus, Ohio. Dr. Bosslet completed his fellowship in pulmonary and critical care medicine at Indiana University, where he was the chief fellow in his final year of training. And during this time, he also completed our clinical ethics fellowship at FCME and also obtained a Master's of Arts in Philosophy and Bioethics. In 2015, Dr. Bosslet co-chaired a multi-society statement entitled An Official ATC, AACP, ACCP, ESICM, and SCCM Policy Statement regarding responding to requests to potentially inappropriate treatment in intensive care units. This statement provides guidance to clinicians on how to handle dispute requests for treatments in the ICU. Amy Martin joined us here at Indiana University Health as the Executive Director of Clinical and Organizational Ethics in October of 2018. Amy's interest in bioethics began as an undergraduate in DePaul University, where she was a philosophy major. Forging a path to a career in bioethics, she continued her education at Loyola University, Chicago's Department of Philosophy and Applied Healthcare Ethics. During her undergraduate and graduate degrees, she interned at the University of Minnesota Center for Bioethics, was a clinical fellow at Lutheran General Hospital in Park Ridge, Illinois, and taught dental ethics at University of Illinois Chicago Dental School. In 2007, Amy started her career as a clinical ethicist at Presence Health, which is now Resurrection Health, where she remained until joining IU Health. Outside of her work as a clinical ethicist, Dr. Martin has been an adjunct professor at Loyola University Chicago in the Department of Philosophy and a member of the state task force concerning matters in healthcare ethics here in Indiana. Before I turn it over to our great speakers today, and before we begin, I want to just take a moment to remember and to honor the 12,950 COVID-related deaths that have occurred in Indiana since the COVID crisis began, 970 of those at IU Health hospitals. And to also remember the thousands of COVID patients our IU Health hospitals have treated and discharged. And so thank you. Thank you to our IU Health team members and all the other team members, all the other hospitals that are listening in, who have worked and worked and worked to care for these patients these last 14 months. Drs. Bosslet and Martin, I will turn it over to you now.
Thank you, Robin. I'm just going to start by talking a little bit about what we're going to talk about in kind of our process for today. So we're going to talk about the development of crisis standards of care for ventilator allocation. We'll talk sort of all about how it came about and everything, but we're going to try to do 30 to 35 minutes of talking about it so that we leave plenty of time for questions. And Robin, I want to thank you for starting out by sort of acknowledging and calling attention to all those who's both lost their lives and also given so many hours in caring for these patients over the last year. Because I think that's by far the most important thing. And I think it's important that we sort of center on that as much as possible as we get into this, because that, number one, that's why we do this, but also, like, as we talk about this, it's a little, this maybe get a little uncomfortable when you sort of think about it in contrast to sort of those individuals who's lost their lives. So I'll kind of leave it there, but we want to leave a ton of time at the end for questions. So we will go ahead and get started.
Thanks, Gabe and Robin. So the way I thought about presenting this was kind of to tell our story, kind of our response to the knowledge that we were going to have to address a pandemic. We're going to go through what our allocation protocol looked like and how we operationalized it. But this story feels very personal. And so it's kind of a memoir of sorts of how we remember addressing this essentially a little over a year ago, how we've documented. We documented a lot of our process, but just know that it's filled with and fueled by copious amounts of uncertainty, a dash of anxiety, a touch of humor, a sprinkling of tears, and a great hope that we would never have to use any of this work that we spent hundreds of hours on. But with the hope that maybe what we'd use it for was a talk in the future. And here we are giving that talk. Writing an allocation protocol or a protocol for crisis standards of care is something you do in ethics training. It's not something you ever think you'll actually do. And I was trying to liken this maybe to the Super Bowl of an ethics career, but it's more like the Olympics of an ethics career. It was a long process. And from the beginning of March to mid-April, I'm pretty sure that I didn't see or talk to any other human being more than I talked to Gabe Bosslet. And so I'll hand it over to him to tell our origin story.
So for me, my role in doing this work was not serendipitous. It was tragedipitous. The only reason that I had the time to participate in this work, because frankly, this was about 6 or 8 weeks worth of work that really encompassed every waking moment of my time and some of my, frankly, sleeping moments. There were multiple days where I woke up at 3:30 in the morning working on this. And the tragedipity was that as the pandemic was bearing down on us, my wife was diagnosed with breast cancer. And so we were staring down what we knew to be something that was going to really wash over our hospitals. And it was, Amy used the Olympics analogy before, and I'll use the same one. It was the Olympics of critical care medicine. It was something that I'd studied decades for and was absolutely prepared to do. And I was going to miss it because Sarah was going through chemotherapy, and I was told in no uncertain terms that I was not to go into the intensive care units and care for individual patients. And I was super thankful to have colleagues that were willing to sort of go into the fray on my behalf, but it left me with a lot of nervous anxiety and a need to sort of feel like I was helping. And so if I'm honest, these crisis standards, it's not something that I'm super proud of, but it gave me a way to try to help care for patients during a pandemic in which I was not going to be able to care for patients, if that makes sense. And so kind of that's why I had the time to be able to do this.
So we knew that we had to come up with something. We saw this disease bearing down on us, and we knew it was going to be a disease that was likely to affect respiratory systems in a way that we might need to allocate ventilators. So we had to sit down and decide, what are we going to do with this? How do we move forward? We had a document from 2014 but how were we going to think about movement forward and operationalizing these things? We didn't know enough. We didn't know who this was going to affect. Was it going to be young or old people, people with certain comorbidities? We didn't know how it was going to manifest. We didn't know where it was going to manifest itself, if it was going to have more of an effect on urban populations or rural populations. We didn't know what we were doing in terms of what it was going to look like. So we knew we had to build an allocation protocol. We also knew we had to address other ethical things that were happening at the same time. How were we going to look at CPR and its utilization? How are we going to allocate other resources like PPE, ECMO, personnel, et cetera? A lot of people say it was like building a plane while it was taking off, but I think of it more like trying to design a blueprint for an airplane without knowing how many seats or doors it would need or how much it was supposed to weigh while building it while taking off. Gabe?
So all of the work that sort of Amy just described from a 30,000-foot view and that we're going to describe really granularly in a few minutes took place between March 8th and April 3rd, 2020. So when I go back through my notes, and I'm surprised at the level of notes that I took, you know, the first emails about this started around March 8th, were emails from Joe Smith and Lyle Fettig at Eskenazi Hospital to me saying, hey, have you thought about this? Because this is coming. And the final draft of the crisis standards were done, were published on April 3rd. So in less than a month, we went from knowing something crazy was coming and knowing that we had to figure out some way to be ready for the worst through, I don't want to say we went directly, we went through, and I counted, there were 29 versions of this document from start to finish, but it happened extremely quickly. And I put this slide together just to sort of show people all the things that were happening in the background with the pandemic in the state of Indiana. If you're interested in it, if you go to WFYI, they have an amazing timeline there, actually kind of an interactive timeline that I found that's really cool. But I put this slide up just to denote, you know, that this was a lot of work in a very short amount of time. And that's going to cover some of my reflections at the end.
We started to think about, in our discussions with a number of people, this certainly by no means was just Gabe and I doing this, but we started to think about the 2014 guidelines. I talked to my boss, Dr. Paul Helft, about the 2014 guidelines that he had helped write for the state about allocation or crisis standards of care, specifically for a pandemic influenza after H1N1. And thought that we were in a pretty good place with the 2014 guidelines. But then as we started to look at it, we started to realize that it was going to be a little bit more difficult to operationalize than we thought it might be. So we started to think about what about this did we need to revamp in order to make this workable for our hospital systems. So we started to think about, should we move SOFA scores to PLOD scores for the pediatric population? Do we need to think about the modified SOFA scores so that hospitals don't have the wherewithal to draw labs, could utilize bedside criteria to think about scoring people in a timely fashion? One big thing that started to rear its ugly head was, as you'll note on the right side here, there were starting to be lawsuits by the disabilities community being concerned with allocation protocols and exclusion criteria. The 2014 document had exclusion criteria, and we wanted to pivot away from that in a way that we were considering protocolization of not only lives saved, but life years saved as our threshold. And then to move away from tiebreakers as purely just lottery, looking at things that Gabriel described, such as life cycle years and things like that. So we started to make some changes and think about really how do we take this protocol and add to it in a way that we can move this forward through our system to operationalize.
So in doing so, we went out to see what other places had done, and we got, and a lot of places were working on this. So I reached out to critical care colleagues around the country and say, hey, what do you guys have? What are you working on? And so we got multiple states and organizations, crisis standards guidelines, and a lot of people were taking a really hard look, like we were, at previous guidelines they'd written, and realizing this may need tweaked a good bit, exactly like we were. So we got documents from Yale, state of New York, Pennsylvania, and really kind of took a hard look at all of these and stood them up against our 2014 guidelines, and realized that there were, we thought, ways to sort of make this better, but also make it very similar, because the work that had gone into 2014 was really pretty awesome work, actually. I think that really, as we were doing this, we sort of felt like we were doing this with a gun to our heads, frankly, with what was coming. And so I think that we were able to focus in a way, and really had to look really granularly in a way that the people who wrote the 2014 guidelines, they just didn't have that need at the time. They could sort of be a lot more thoughtful, a lot more 30,000 foot. And so we took a lot of these, and the one that stood out to me most was from Pennsylvania. To us, most was from Pennsylvania, where a gentleman named Doug White, who actually happened to be my senior mentor, the mentor that I worked with on the potentially inappropriate care guidelines. And he had written a lot between 2014 and 2020 about triage protocols and the ethics behind triage protocols. And so we used the Pennsylvania document and some publications that he had as sort of the backbone of what I'm about to present. And so really the ethical underpinnings of this, and sort of the nuts and bolts of this, are a few things. First, it eliminated strict exclusion criteria. And I'll talk in a minute sort of about what it replaced, what replaced that. It established triage teams. So teams of individuals who were not at the bedside, were not caring for patients. That would include one clinician. It was 3 individuals, because there was some judgment that was going to go into this inevitably. And so having 3 people to sort of be able to break ties, we thought was important, to make the triage decisions, but not to be the ones to communicate those decisions. We thought it really important to sort of protect these people who were doing this hard work from having to be the people to relay the product of that work to the families and the patients at the bedside. This upset some clinicians. Naturally, as a clinician, this is a place we are almost never put, right? A place where someone else says, this person doesn't get this anymore, and then we have to go and tell them that. But we thought it important to make sure those triage teams were not put in that position. It used an allocation criteria that looked at both maximizing acute ICU survival, but also long-term survival or life years saved. So acute ICU survival for adults is the SOFA score, for peds is the PLOD score, and then an assessment of comorbid conditions that would map a little bit, at least in theory, onto long-term survival, and I'll show this in a second. The tiebreaker that was used was life cycle considerations. And then every so often, every 48 hours in the protocol, patients are reassessed for how they're doing. If they're getting worse, then and this reassessment determines whether or not they would get continued therapies, depending on whether or not there were people that were waiting. And I'm going to explain all of this in a lot more detail here as we go through some examples. There are a few caveats, though. First, it's important, we thought it important that hospitals exhaust all transfer options, and this is essentially what happened. If you look back in March and April of last year, and even December of this year, and frankly, December of this past year was worse than April of the year before on a statewide level. Indianapolis was probably, about the same. We were a little bit better prepared in December, I think. But exhausting all transfer options so that we wouldn't have to enact this was important. Maximizing all ventilatory capability, meaning hospitals should use anesthesia machines to ventilate patients if need be, transition BiPAP machines, which are usually non-invasive, to invasive ventilation if that's possible. And then keeping in mind that all patients who require ventilators should go into the triage pool, not just COVID patients. So anyone who required a ventilator at the time of crisis standards would be included, not just patients with the underlying pandemic disease. And the caveat also is that no triage process will be perfect. So I'm going to go through the process, and if it doesn't make you queasy, then something's probably wrong, because this is not medicine as we are used to practicing at all. This is sort of population health-based medicine, not patient in the bed-based medicine. And it's, if you're a clinician, making that transition can be very difficult. I'm just going to point out this picture. This is a picture of a ventilator that we split to ventilate 2 patients at once. And I had a fellow working on this around the clock for about 3 weeks. And we actually were able to develop this. We never had to use this, but I show this to say that this is the lengths at which we were willing to go to avoid having to do what we're about to talk about. We never used this. I suspect we would have used this before we would have used our triage guidelines, frankly, and just done our measured best to provide whatever we could. But we were literally doing anything and everything we could to avoid having to use the guidelines I'm about to go over. So this is the score. This is the scoring system. So it uses the SOFA score, which I'll show you in a second, to assign a score of 1, 2, 3, or 4 based on the SOFA score. And then you got a score of either 3 or 4 or 0 based upon your comorbidities. This is the SOFA score. It's basically a physiologic organ failure score looking at 5 different organ systems. It's graded on a score from 0 to 20, 0 being the least likely to die or the most healthy, least number of organ failures, to 20 being the most number of organ failures, most likely to die. Keep in mind, the SOFA score is, as a general rule, used for research to quantify severity of illness. It has been written in crisis standards before. We're not the first one. It was actually part of the 2014 guidelines, but it was not designed to triage patients for ventilator utilization. So we take this SOFA score, and you can see here, anything greater than a 12 gets a score of 4, anything less than 6 gets a score of 1, and then we add on this major comorbid conditions. So if you have no comorbid conditions, for example, I would get 0 comorbid points because I have none of the conditions in here or in here, or conditions that are analogous to this, right? So these are not expected to be all inclusive, but sort of paint a picture of the severity of disease that would get you either 3 points for a major comorbidity or 4 points for a severely life-limiting illness with essentially a survival of less than 1 year. So you take the SOFA score. Let's say if someone's have a SOFA score of 15 with a major life-limiting comorbidity, they would get an overall priority score of 8. You would add 4 here to 4 here, and they would get a overall priority score of 8. In order to understand really on a granular level how this works, you have to really look at an ICU, or actually, so let me back up. So then these priority scores are put into categories. Red meaning most likely to get a therapy, most likely to live, most life years potentially to save, down to yellow, which is most likely to not benefit from therapies, and or the least life years available to save. So they are put into this priority score. And so let's look at a scenario. So this is a scenario with Hospital X. Hospital X has a 10-bed ICU, all of which are taken with the patients that you can see here. And this patient comes in with COVID-19. So what would happen is that triage team that morning would have scored all of these patients and categorized them, right? So the red are the patients who are most likely to survive with the lowest triage score or prior. I'm going to use triage score and priority score interchangeably here. But the lowest triage score, so the most likely to survive, and the patients in the yellow are the ones with the highest triage score or the least likely to survive. So we will look at all these, and let's say that this COVID patient has a triage score of 1, so they're very, very likely to survive. And the triage team has scored all these patients and put them into these categories. Then it becomes, okay, we have 4 patients that are in the, 3 patients that are in the yellow triage score. So how do we determine which of these patients gives up the ventilator when this patient hits the door? So we have a 3-tiered tie resolving situation here. The first is life cycle considerations, not absolute age, but life cycle considerations with admittedly arbitrary cutoffs between the stages of life. And someone in a lower stage of life will be triaged over someone in a higher stage of life. So if you look at the patients right here and look at their age, they are actually all in the 41 to 60 life cycle. And so that is a tie. So then we go to the next thing, which is the absolute triage score. And you can see we have 2 patients with the triage score of 6 and 1 patient with the triage score of 8, which means that patient with the triage score of 8 would be the first patient that would be set to lose that ventilator in the scenario in which someone else with a lower prioritization category would need it. Now, if there would be another patient come in, then these last 2 patients that are left have the same life cycle stage and the same absolute triage score. And so they would be determined by a flip of the coin, which is a very uncomfortable thing for me to say. Another way, so what if we went into the orange category? We had enough patients that we had to get all the way down into the orange. Same thing, life cycle considerations first, and we have 2 patients in the 41 to 60 and 1 in the 37. And so the person who is 37 years old would be the last person to lose the ventilator. These 2 patients have both the same life cycle consideration, the same triage score, so they would be determined. Who would give up that ventilator would be determined by lottery. Quiet. Oh, so sorry, my dog's about to bark at a dog that's outside. Okay, it also includes reassessment of each patient every day. Out, come on. Sorry. Pandemic presentations. So it also include reassessment of every patient every 48 hours. Those patients that are improving, keep the vent. Those patients that are clinically worsening are made available for patients who come in and need a vent if that scenario is there. And those who are essentially unchanged, this is where it gets tricky. It's a discussion with the triage team and the bedside clinicians and clinical judgment as to what happens to those patients, which brings about a level of subjectivity that is admittedly uncomfortable, but is almost impossible, frankly, to avoid.
Thanks, Gabe. So we needed to then figure out how on earth we were going to operationalize all of this. And as I've noted here, there were so many moving parts. We needed to utilize all of our resources to move the process forward and do all of the work simultaneously. And I will send out an apology to anybody who, like Gabe, I was working on things at 3 in the morning because I couldn't sleep, and I might have sent you an email, for which I apologize. But so we first had to figure out how are we going to operationalize practically a SOFA score? And what we wanted to do, and our IS team moved quite quickly on, was to build this into Cerner, to build the calculation of SOFA right into the Cerner platform to create a dashboard so that we didn't have to deal with it by our triage teams because it would take a long time. Gabe will speak to it in a moment here. I think he spent a lot of hours hand calculating SOFA scores for our practice patients. But in terms of doing it in a quick and timely fashion, if we were going to get bombarded with a multitude of patients at one time, we wanted Cerner to be able to calculate this.
Yeah,
Gabe,
you can imagine for larger hospitals like Methodist, there are the potential of more than 100 ICU patients at any one time in there. Calculating those SOFA scores would take a long time. In fact, I calculated how long it'd take. It took about 1.5 minutes per patient. So you're talking about a couple hours worth of work for something that could be done kind of on the back end with programming. And the Cerner team was unbelievable at getting this. We went to them with this request and had a ton of meetings, and they were able to turn it around really quickly. And that was huge for a large system. A smaller hospital could do this relatively easily in a smaller ICU on a daily basis. But in a large hospital like Methodist, getting this done was imperative.
Yeah, and I kudos to Gabe as well. He spent a lot of time helping validate this new thing that was built into Cerner in a timely fashion. And if anybody's built anything in Cerner, they know it takes a long time normally. So everything in our process went through Incident Command. Incident Command was the place that all decisions for the pandemic have gone through. I worked very closely with Kevin Armstrong, who was a wonderful leader in dealing with issues concerning ethics at the Incident Command level. I'm going to also make a note here that in talking to my colleagues that do ethics around the US, no other Incident Command was run quite as well in terms of utilizing ethics as part of their structure and their thinking. So kudos to IU Health for being really progressive in that way and thinking about the importance of ethics in a pandemic. Incident Command, so we took our vent allocation protocol to Incident Command a number of times when we kind of would do a little switch on what we were thinking about utilizing as our allocation protocol. The critical care committee would then look at it and give us the go ahead to say this is something that they would think would be appropriate for the entirety of our system. Simultaneously, we had an ethics advisory team with ethics specialists. This was comprised of one person from each region. Each person occupied a different role in the world of healthcare, everything from chaplaincy, nursing, physician, what else do we have? Administration, et cetera. And these advisory teams did a number of things, but in terms of our allocation protocol, they looked at it with a really nice skeptical eye in terms of how are we going to implement this and how would this be feasible in their locations. They made it specific, helped make it specific to their locations. And then they also helped create our vent allocation teams. Our vent allocation teams were, each region had a team, including Riley having its own team. And these teams were made up of 12 to 27 team members. These team members were identified for a multitude of reasons by our advisory team leaders. And they started to do things like create an on-call schedule for the triage teams that were determined locally, participated in Incident Command, and operationalized a workflow scoring system. There's a lot that the ethics advisory team did to operationalize something luckily we never had to use, but it was up and running and ready to go. And in part of doing that was to create education. We kind of on a dime were able to pivot all this work we had done to create not only scoring sheets, et cetera, but to create education. We were able to get 102 people together with 1 day's notice, which I think actually was comprised of every team member that was on a allocation team to come to one of two sessions to be educated about what the protocol would look like and how they, as team members, allocation team members, would operationalize it. Once we were done with all of this, well, maybe more simultaneously, we took this to the Indiana Coalition for Patient Safety, which is a work group. There's an ethics work group there that is comprised of ethics people from all of the major systems in Indianapolis. And we asked them to think about adopting this vent allocation protocol so that we wouldn't be doing something different than another hospital. We, at the same time, kind of asked IHA and the state to consider adopting the protocol, which they didn't really have time to do because they were dealing with, umpteen other things. So they, what they did to give us space to really protocolize this was they took down the 2014 protocol from the website.
So clearly no system will be perfect. This is no exception. And as I very quickly went through things, there may have been things that sort of you picked up on that, hey, why did you do this? And we're happy to answer any questions about that when we're done here. I'm going to talk a little bit now about a couple sort of caveats here. First, SOFA scores don't work that well for COVID. they don't work that well for triage guidelines, period. Specifically, the cardiovascular domain doesn't really map onto kind of the way pressures are used anymore. The neurodomain is kind of useless because these patients are usually sedated and paralyzed. So assessing their Glasgow Coma Score or their Richmond Agitation Score essentially doesn't work. So we tweaked the cardiovascular and actually eliminated the neuro for ours. But even beyond that, like SOFA scores actually perform worse than just using age for COVID-19. That's basically based upon the clinical dynamics of the disease itself. So I think that you could really sort of look with the side eye at SOFA scoring and ask whether or not it's even reasonable to use in this scenario going forward. And I think you can make the argument that it may not be. The difficulty is that for all comer, this was done retrospectively. As a pandemic is bearing down on you, you use what you have, and SOFA was all that we had. The other things that keep me up at night are our priority score. If you look at our priority score, you get 3 points for major comorbid conditions and 4 for a severely life-limiting condition. The fact that this one gets 3 was a judgment call by our team because a lot of the other states use 2. It doesn't make a huge difference, but we actually had gamed this out in several ICUs and realized that prioritizing life years seemed to work, seemed to have more clinical reasonableness when actually it was given a 3 rather than a 2. So I think you could really look at this and say, really, do we really need to do this? And I think that's a totally valid question. The other thing that keeps me up at night is we didn't assign points for pregnancy or take away points for pregnancy. And I think you could make an argument that should be the case. Number one, these people are generally young, and number two, there are 2 lives at stake rather than 1. And several states actually do have a carve-out point system where they sort of just subtract a point or 2 from that triage score for patients who come in with pregnancy. And so the bottom line of all of this is to say that this was done relatively quickly by a team that had a lot of pressure on them to sort of get something workable. And we really, really need at the state level to convene a group, preferably by the State Department of Health, in my opinion, to have a really hard look at this and determine going forward whether this is the way the crisis standards that we want going forward. In the 2014 guidelines were done by the State Department of Health, codified on their website as the place to go. These guidelines, as we developed them and rolled them out, became the de facto guidelines. The state, like Amy said, took down the 2014 guidelines as we sort of interfaced with them. The IHA passed this along to all of its member hospitals, which is essentially every hospital in the state. But we really need to do kind of a debrief on what works in this system and what doesn't, because I don't pretend that our April 3rd, 2020 crisis standards is what we should utilize going forward. So there are a lot of people who made this possible well beyond Amy and I. We want to sort of just point out some of them who helped give guidance and lent an ear and counsel in sort of both developing the ethical underpinnings, but also sort of the logistical legwork of getting this from point A to point B. And did I miss anything, Amy? Okay.
Nope.
That's it.
I think we covered all of it. Now we would be happy to field any questions. I think Robin is going to.
I am. So I see that people have raised their hands. So what we're going to ask you to do is that just because there are so many people on, we don't unmute anyone. So please go ahead and put your question in there, and then in the Q&A, and you should see at the bottom, there's a Q&A section. Please put it in there, and then I will make sure to get it to them. Okay, so this is from Larry, Amy. So Larry Goretto. Larry would like to know, what are the factors behind not including an adjustment for women who were pregnant, Gabe? You talked about that.
Larry, I don't think it was, like purposeful. Like it was one of those things where, April 3rd was sort of we needed to get something done, and we could have tweaked this for months and months. We could tweak this for years going forward. And we sort of got to the point where we just realized like this needs to be good enough, and there are going to be judgments that have to be made, and let's just roll with this. So I don't think it was like an explicit decision. It was just like, that was one of about 50 different questions that were on the table. And we were just like, we sort of just need to move this forward because we were I'll be honest, I remember the April 3rd document because we actually were like, we think we're getting close to having to use this and we've got to roll it out. Wasn't that your impression, Amy?
Yeah, absolutely. I think we just, at some point, kind of via our incident command, it was time to have something that we could operationalize and not just, as Gabe points out, we could have just nitpicked it and made it a little bit better and a little bit better, but we needed something to work with.
All right, the questions are coming in rapidly. How does the SOFA score compare with the APAHE3 score?
Yeah. So Eric, and I'll try to answer quickly. So the Apache 3 score is another severity of illness score. I've not done an in-depth analysis of the two of them side by side. They're the two most common that are used. I actually think they're somewhat interchangeable. If you look at critical care studies, people will either use the SOFA or the Apache 3 at this point. Although I think now more people are using the SOFA score. So I think they're pretty comparable. And I think they're pretty correlative. Most of the triage guidelines use the SOFA score.
So someone has observed that you use the statement, lose the ventilator. Does that mean you actually took patients off the vent to give to another patient?
Yeah, it does.
Well, we never had to.
We didn't have to.
But that's what it would have been.
Yeah, we never had to do this. Thankfully. I mean, I'll be honest with you. I actually think they're doing this in India right now.
Yes.
I think that India is far worse than we ever were. And I think they're probably doing, I haven't seen any publications, but just in reading what I've read, they're doing this. We never had to do this, thankfully. But yes, that would be what happens.
Our respiratory therapy team, I know, works so super hard to reallocate all of the vents in IU Health system. Was there a standard for communicating this decision-making to affected patients and families?
There was not. It would, the only standard that we outlined in the guidelines was that it was to be done with by the bedside teams. However, in the guidelines, there was a table of, and I don't know how helpful this would have been, frankly, of potential language for people to use because we realized this was an uncomfortable place. So it wasn't, we weren't overtly prescriptive, but we did offer some language assistance. And I'll be honest, the first time this would have happened would have been a very uncomfortable conversation between, well, probably myself and the bedside clinician, because if I was a bedside clinician, I would be just at my wit's end. But honestly, if you think about it, by the time we were in it, it was a disaster, okay? It was a disaster, and we were nowhere near doing this. If we get to where we have to do this, it's like battlefield triage. It's like, bombs going off. I mean, it's literally like, I cannot imagine how bad it would be. And we would literally be to the point where everyone would just be doing their measured best.
And we had also talked to Jay Foster and really looked at how chaplaincy could have aided us in these awful conversations that we, again, hoped no one would ever have to have and are thankful no one ever had to have.
So this is sort of a follow-up question to that, parallels a little bit. It says, you mentioned the individuals making the triage decisions were different than the ones who were communicating the decisions with the family and the patients. Who were the individuals who would have had to, because again, you have reiterated that we never had to do this, but who are the individuals who would have had to communicate those triage decisions? And can you maybe talk about what the experience, imagine what the experience might have been like for them? And I think you've touched upon that a little bit.
Yeah, I mean, it would be the bedside clinicians. It would be the ICU teams, right? I mean, that's who it would really be. It would be the ICU teams, and these are teams that are used to having these conversations. We could have a whole hour on whether or not they do it well or not, but they're used to doing it. But they're not used to doing it in this way, right? They're used to doing it because they've made a clinical decision that we should limit therapies and are going with that. This is a totally different scenario. This may be a situation in which they disagree with this, but prudential circumstances necessitate that this happen. So yeah, it would just be the bedside teams, including, and they could utilize whoever they would need to sort of help with these discussions: palliative care, chaplaincy, social work, whoever needs to be involved.
One of the problems we encountered was there was no promise of immunity for those who took someone off of a ventilator.
Our legal team did address these queries and sent us a nice memo to send out to our ventilator allocation teams in support. There are a lot of standards in legislation that actually speak to this. I certainly can't speak to this. I am by no means a legal person, but we were definitely in consultation with our legal team as we went through this.
And I think, wasn't there an executive order that addressed this, or no?
There is some level of immunity. I can't describe it particularly well, but it does exist.
Yeah.
So here's our question from one of our partners over at Community. Are you aware if this was necessary to put into place anywhere in the United States?
I don't think as far as I know, it never was implemented anywhere in the United States. I think we would have seen a lot of talk in the press about it had it actually happened to any significant degree. Simultaneously, I think if it didn't happen in New York in the beginning, it probably wasn't going to happen anywhere. But I don't know this with any degree of certainty.
It got close in Texas in the summer. There were actually articles that, they were having to ship patients hundreds and hundreds of miles away. But I don't think they had to use this.
So Chaplain Eric is wondering about whether what you developed, could it be translated into a tabletop exercise?
Yeah, it could. In fact, we sort of did this. I mean, I used the word game before, which is probably a really bad choice of words, frankly. But, we did this with a couple of ICUs where I literally calculated all of the SOFA scores and calculated the triage scores for all the patients, and would literally go to the bedside docs and say, look, here's what's going on. Here's what we're doing. If today you guys were out of vents, this patient would be the first patient that went. And part of the reason why we did that was, number one, to test out the scoring to make sure that it sort of made sense. But the other thing that we had to do was, the score had to be sort of pass a clinical reasonableness test, especially if we were going to ask bedside clinicians to be the ones to communicate the decision. It would have to be a decision that would somewhat kind of make sense to them. And so we wanted to make sure that was the case. So we did do this to some extent, although it could probably be done in a much more robust manner, frankly. And we would probably benefit from doing that, honestly.
Do you think about giving provisions or preferences to the healthcare workers who contracted COVID caring for patients?
Amy, do you want to?
Sure. We did talk about that, and I can't remember totally, but there was a lot of discussion about kind of the ethical parameters of allocation of ventilators as a tiebreaker to caregivers who contracted COVID while caring for COVID patients. We had a lot of discussions around it, and in our final document, left it as an appropriate consideration, but not part of our protocol on the back end. Something else that would be worthwhile to consider discussing. As you see, we did it with the allocation of vaccination to some degree, although the conditions of allocation are very different in an ethical sense for vaccination as they would be for a ventilator, but certainly something that we did consider and did write about a bit in our protocol.
And I think actually Pennsylvania's protocol includes the fact that frontline healthcare workers do actually get priority in their state's guidelines. And the ethical reasoning for that is that they're needed to care for the other patients who are going to come in. At the same time, figuring out what frontline means gets really sticky from an operationalization standpoint. So we elected to leave it out.
Where did the use of anesthesia machines use in the critical care units fall into this discussion?
They were just another they were just another ventilator. They were used as a ventilator. So, there were times, I think, I don't remember for sure, but where patients were ventilated in the OR because that's where the ventilator was. So it was literally just, it didn't have any special place in the protocol. It was just, they were used as ventilating machines to reduce the likelihood that we would have to get to this point.
Where does this document currently live? Is it just within IU Health or is it in the Department of Health? Where is this now?
It currently lives in each hospital system that utilizes it. There is no state level acceptance or promotion of this document, which is something that Gabe and I have talked extensively about, moving to hopefully more of a state level. We've also talked to Jim Fuller at the coalition to really talk with the members of the coalition in trying to support this moving forward.
And we reached out to the state as we were doing this work and sort of engaged them in thinking about this as well. At the time, for a whole host of reasons, they just didn't have the bandwidth, and I don't blame them. Oh my gosh, the work that they've done has been Herculean. So, we kind of took this on. However, it's probably time to re-engage them soon once the pandemic has really kind of simmered down, to talk about re-engaging regarding this, because I think this needs to be done at the state level.
I'm going to kind of combine two questions. So going forward, prospectively, what would you consider doing differently? And then are there takeaways from this planning discussion and what you've learned that you're adding to current practices, potentially even with non-COVID patient care?
I would say that what we discovered as time went on was that the limiting capital was not a machine, but humans. This was designed around machine limits, but we were going to run out of human capital far before. We were going to way overspend our physician and nursing and respiratory therapy capital far before we got to the end of our ventilators. We actually had, I don't remember what % of ventilators we got to using in IU Health at maximum. Do you, Amy?
No,
it wasn't. I don't even think we got to 70% use, did we?
No, I don't think so. We were certainly in a zone where we were thinking, oh, we need to pay close attention, but it never got extraordinarily scary. And if my memory serves me well at all.
And the difference between human capital and the ventilator capital is you can stretch human capital sort of very, very, very far. So that's one thing that we learned, that as the pandemic wore on, we all started screaming about, because it wasn't the machines that were limited, it was the humans. What are the other things we learned? I'll be honest. I learned that the system did a pretty darn good job, like from the C-suite down, in ramping up. We ramped up our ventilator capacity massively with a significant financial outlay to sort of get ready for this in a way that I've never seen before. And I was impressed. Truthfully, I was very impressed. What else do we learn, Amy? Anything else?
Well, anything that's affecting current practice?
I think so much of the thinking, I've talked to Kevin Armstrong quite a bit about this, and just so much of the thinking and the ability to be agile and pivot and really think through an ethical lens, which I think IU Health has done a fantastic job of during a pandemic. And I think generally speaking at least that's been my experience in my 3 years having been here. But really just really trying to continue to emulate that and be able to move through decisions a little bit more quickly with still with a critical lens.
So Larry Gretto is out in the Seattle area, and he shares that different hospital systems were in sort of a consortium where resources across the systems were shared and kept the individual hospitals out of crisis. Was anything like that done in the Indianapolis area, or was it ever considered?
We certainly did it, as a health system. We were moving ventilators around without question throughout the system. And there was certainly discussion about sharing resources locally within Indiana. And I think even nationally, there was some discussion around that, whether or not we'd be able, to send vents out of state to places that were in dire need. So certainly was addressed, and I think the consortium existed, probably not to the degree, from my understanding, that it did in Seattle, though.
So,
oh, Vicki.
I'm only smiling because Vicki Strzok is answering the question. Vicki was so instrumental, I know, in doing so much of this work with the respiratory therapist. But Vicki wants to know, did you send vents out to states via AH? Oh, Vicki is answering the question. Sorry. Vicki is answering the question. We did send vents out of state via an AAH program. What does AAH stand for, Amy?
I am not sure exactly, but I think that was the vent sharing program that we had entered into with other hospital systems. And I think our threshold number might have been around 40 vents. I'm unsure of that, Vicki.
Oh, Vicki answers that it's the American Hospital Association.
Oh,
super.
Right.
Thanks, Vicki. So Chaplain Will at Ball would like to know, can you speak to the critique or the discussion related to the scoring model that adding comorbid conditions may disproportionately impact people in racial or ethnic minorities?
So that was something that was noted in discussions about the original paper from Doug White, that racial disparities were in some ways answered via this model and the scoring system. Gabe and I talked about this at length, and for us, it really was about comorbidities more than anything else, and survivability, which we didn't see how, or we couldn't parse out how this was answered by the scoring system as it was. Gabe, do you have any thoughts on that?
Yeah, I mean, what I think Will's getting at, and it's a great point, is, I'll be honest, I mean, a triage system based on comorbidities basically bakes in, healthcare disparities into the system, and it was done. It's not baked into the triage protocol, but it's baked into our health system, and it disadvantages those who are at a disadvantage regarding social determinants of health. We had lots of conversations about this, and a lot of sort of mental gymnastics figuring out if we could sort of address this. And we sort of came to the conclusion that trying to fix centuries of these disparities with a gun to your head triage system for a pandemic probably was a fool's errand. So we have a lot of work to do on social determinants of health, on racial disparities in medicine and healthcare. And we need to be doing that heavy lifting all the time. And we did our measured best in a difficult time to give thought around that and realize that it wasn't going to be something that was fixed during the pandemic. And I hate to say that because it sounds terrible, but it's true.
I'm aware that we have 1 minute, so maybe maybe it's a yes, no question, but there are national guidelines for treatment protocols and like sepsis and such. Have steps been taken by any groups to create national guidelines in vent allocation?
No. I mean, we couldn't even get the state to do it, right? I mean, so getting it done nationally, I think is probably a non-starter here.
It would be nice.
Yeah.
Potentially like needs some more space between now and then when people can breathe a bit. So
yeah.
Gabe and Amy, thank you for what you have done for IU Health and for the state, and Gabe for your Facebook page. Thank you so much for what you've been doing to try to educate Indiana and anybody else who's who's been a part of Gabe's Facebook page. So, and thank you everybody for joining us today, and we will see you again in the fall.